Hello and welcome back to the Academy of Anaesthesia. We're going to continue in this three-part series on vomiting. In part 1, we covered the physiology of vomiting and the reflexes involved. Today, we will discuss the classification of antiemetic drugs and describe the pharmacology. If you missed the first part of this series, pause this video and go back and watch it as we will be referencing it a lot in this one. It's linked in the video description below. The pharmacology of antiemetics is a classic question of the FRCA as it's relevant to everyday practice. We'll go over how to classify each drug based on the previously discussed physiology. Let's begin by reminding ourselves of the chemoreceptor trigger zone and the receptors we now know from part 1. By knowing the different types of receptors involved, we can classify the drugs based on that prior knowledge. Therefore, we can broadly classify them into dopamine receptor antagonists, muscarinic receptor antagonists, histamine receptor antagonists, 5-HT3 or serotonin receptor antagonists, NK₁ or neurokinin 1 receptor antagonists, and other miscellaneous drugs that don't fit into this classification. Now, just a few points before we discuss the individual drugs. You don't need to know every single detail about every single drug, but the principle of if you use the drug often, you're expected to know more about it applies. Knowing a few unique facts about each drug, however, and then applying a bit of common sense and experience can get you far in the exam. Therefore, I won't be reading out all the technical details of each drug as I don't think that's helpful, but instead I'll give you the most important and unique points about each drug. I'll also give you the numbers needed to treat, or the NNT, for the most common drugs that we use, as sometimes it does come as part of the question. NNT in simple terms is the number of people who would need to be given the drug for a single case of the indication to be prevented. For example, if an antiemetic has an NNT of 4, if you give the drug to 4 people, you will have prevented 1 case of vomiting. The other thing to mention is that although these drugs are commonly classified into these categories, real life isn't as simple and there are multiple mechanisms of action for each drug. This classification in pharmacology textbooks is based on what is believed to be the drug's primary mechanism of action for antiemesis. With that out of the way, let's go ahead. Dopamine receptor antagonists include prochlorperazine, metoclopramide, droperidol, and domperidone. These mainly act on dopamine D2 receptors on the chemoreceptor trigger zone. Prochlorperazine is our first drug and acts on dopamine receptors, but also has some antimuscarinic properties. Its main side effect, to remember, is the significant risk of developing extrapyramidal symptoms. Children and young adults can be particularly affected. For post-op nausea and vomiting, routes such as the IM injection and the buccal tablets exist, and that's because of its low oral bioavailability. The next drug is metoclopramide. The numbers needed to treat for metoclopramide is 8. Metoclopramide has antidopaminergic effects, but it also has the unique feature of being able to increase gastrointestinal motility and is sometimes used as a prokinetic agent for that reason. The mechanism behind this is due to its additional effects on serotonin 4 receptors. Therefore, it has side effects such as diarrhea, as well as the usual antidopaminergic effects such as extrapyramidal symptoms. Rarely can it cause neuroleptic malignant syndrome or oculogyric crises, but these aren't the first side effects I would recommend mentioning in the exam. Start with the common stuff. And now on to droperidol. Because droperidol is used in some rare settings in the UK, I'll mention briefly that it is associated with QT prolongation at high doses. However, at doses for antiemetic indications, it's safe, and if it does cause any QT prolongation, it's usually temporary. It's very unlikely you'll get asked about droperidol in detail, so remembering this fact alone, along with some prior knowledge of first-generation antipsychotics, should get you through the exam question. Finally, domperidone has the famous and unique feature of not crossing the blood-brain barrier and therefore doesn't worsen any pre-existing extrapyramidal symptoms. It can still also affect other dopaminergic pathways such as the prolactin production pathway, but not the ones associated with dystonic reactions. Just to remind you that the chemoreceptor trigger zone is outside the blood-brain barrier, and so domperidone still retains its antiemetic properties. It can be as part of a rescue antiemetic strategy in patients with Parkinson's disease. The next class of drugs are the muscarinic receptor antagonists. I'm going to add the vestibular apparatus back into this diagram from part 1 with the relevant receptors. The M1 receptor antagonists that are mainly used to treat nausea and vomiting include hyoscine, not atropine or glycopyrrolate. There's no good level of evidence currently that glycopyrrolate has antiemetic effects, and that might be owed to the fact that it does not cross the blood-brain barrier, even though we've just mentioned the chemoreceptor trigger zone is outside the blood-brain barrier. Nevertheless, hyoscine is the main one to remember, as although atropine does have antiemetic properties, it has too many side effects. Hyoscine is also known as scopolamine. It is very effective in opioid-induced nausea, vomiting, and motion sickness because of the M1 receptors on the vestibular apparatus. The side effects of hyoscine are predictable. Think of anticholinergic effects, and you're there. To name a few, dry mouth, blurred vision, tachycardia, urinary retention, and of course sedation because it passes through the blood-brain barrier. Hyoscine might be administered using a patch and applied the night before, but this is usually reserved for the extremely high-risk patients, such as those with vomiting syndromes. Next come the histamine or H1 receptor antagonists. There are many types, but the most common one we use as anaesthetists is cyclizine. This blocks H1 receptors and is effective at treating post-op nausea and vomiting from motion sickness or vertigo. This is again because of the H1 receptors on the vestibular apparatus. Another example where if you learn the physiology well, you can predict the pharmacology. It has anticholinergic properties as well, and so a lot of the side effects are the same as you would get if you gave the patient atropine. If you do give it slowly, as it can cause a significant tachycardia. Next we have the serotonin receptor antagonists. I'll add the GI system back in here from part 1 with the peripheral 5-HT3 receptors. The most common one we use is ondansetron. The numbers needed to treat is 6. Ondansetron is effective for post-op nausea and vomiting and chemotherapy-induced nausea and vomiting, but not very good for motion sickness. You can probably guess why. The reason behind its effectiveness for chemotherapy-induced nausea and vomiting is that chemotherapy causes the release of 5-HT from enterochromaffin cells in the GI tract. These act on peripheral 5-HT3 receptors and stimulate the vagal afferents to the nucleus tractus solitarius to cause vomiting. By blocking this transmission, you block the signal that induces vomiting. The usual dose for post-op nausea and vomiting is 4 mg. There is a high level of evidence in the literature to support giving it at the end of surgery rather than at the beginning. It has side effects such as headaches, flushing, constipation, and bradycardia. The unique point about ondansetron is that it has a dose-dependent relationship at prolonging the QT interval, and so in patients with long QT syndrome, you want to avoid giving it as much as possible. Then come the neurokinin-1 receptor antagonists, such as aprepitant. You don't need to know a great deal about this drug, as it's mainly used in chemotherapy-induced nausea and vomiting and highly specialist centres where paediatric oncological surgeries take place. From an anaesthesia point of view, it's enough to know that it's most commonly used as a pre-medication before surgery takes place. Just an interesting side note about this drug, a meta-analysis has shown that using NK₁ receptor antagonists as monotherapy is as good as giving a combination of several other classes of drug, so these NK₁ receptor antagonists are very good at preventing post-op nausea and vomiting. Finally, in the miscellaneous category, you have steroids, cannabinoids, gabapentinoids, midazolam, ephedrine, and non-pharmacological therapies such as acupuncture. The most noteworthy from this category is obviously the steroids, such as dexamethasone and methylprednisolone. There are multiple quotes for different numbers needed to treat for dexamethasone, but they're roughly around 4. Dexamethasone is effective for chemotherapy-induced nausea and vomiting and post-op nausea and vomiting. It's unclear how its antiemetic properties are facilitated, but they've been used for years for this purpose. The recommended dose for dexamethasone is between 4 to 10 mg, but we normally give 1 ampoule, which is 6.6 mg. There are multiple randomized controlled trials to support giving it at the beginning of surgery. The side effects of steroids are self-explanatory, but they're usually well tolerated as a single dose perioperatively. Just make sure you give it after the patient is asleep, otherwise they may feel perineal burning or pain. The side effect to mention in the exam is hyperglycemia. The guidelines recommend that dexamethasone is still safe to be given to well-managed diabetes patients. This bit is too deep for the exam, but for context, the most recent meta-analyses from 2023 showed that in patients with diabetes, dexamethasone increased your peak blood sugar by 2 millimoles per litre within 24 hours of surgery compared with control. The only group of people who should be treated with caution are the poorly controlled diabetes patients. This last section here is for completeness, so if you want to skip ahead, use the video chapters on the screen. Gabapentinoids, midazolam and ephedrine are all here for completeness. They're not needed to pass the station. There's good evidence that they prevent post-op nausea and vomiting, but they shouldn't be used for this purpose alone when so many other options exist. For cannabinoids such as nabilone, they're used outside of anaesthetic practice, so again here for completeness. They do come up in a separate question on the syllabus on the effects of recreational drugs and anaesthesia, but that's not within the scope of this video. And finally, there is a Cochrane review supporting the use of specific acupuncture techniques, such as the pericardium 6-point stimulation, but for the exam you certainly don't need to know more than that. Before we conclude, I can hear you wondering, we haven't targeted the mu opioid receptor. The best evidence we have is a systematic review and a meta-analysis from 2017, suggesting that low-dose naloxone infusions do reduce the risk of post-operative nausea, but not vomiting, and so it isn't used in practice. And that's part 2 done. There is a fair bit of garnish in this video, mostly to add a bit of context to help you understand, but the key take-home messages are written on the diagram. The tricks to help you remember are that anything acting on the vestibular apparatus is good for motion sickness. Anything on the right side of the diagram is also good for chemotherapy-induced nausea and vomiting. Remember, if you learn the physiology of specific receptors, for example muscarinic receptors, anytime a drug acts on it, you should be able to rattle off a few side effects a priori. The last tip is about numbers needed to treat. Imagine giving your own anaesthetic and your antiemetic strategy as dexamethasone at the beginning of the procedure, ondansetron at the end, and metoclopramide as a rescue antiemetic. The numbers needed to treat are 4, 6, and 8 in that order. We've discussed the pharmacology of antiemetics and how to classify them based on the receptors we learned about in the last video. By knowing how each class of drug acts, you can use a multimodal strategy to counter the risk of post-op nausea and vomiting. For example, if you've already given a dopamine receptor antagonist, to use the same class of drug again is not only futile but can be dangerous. In the next video, we will be going over specific risk factors and predictive models of post-op nausea and vomiting, as well as the recommended strategies from evidence-based guidelines. I've linked my references in the video description below. I hope you found the video useful, and thank you very much for watching.